Hey, good afternoon, everyone. Good afternoon. Thank you for coming and weathering the storm. It's so good to see that the room is full, and we're going to have a great time this afternoon. My name is Lisa Maye, and I'm a senior project associate with Policy Research Associates. And Policy Research Associates is the national leader in behavioral health and criminal justice technical assistance training and evaluation, and has been since 1987. We'll get into a little bit more on that. But I'm here to kind of wet your whistle, kind of prep you all for the importance of the sequential intercept model mapping workshops that are being implemented and rolled out throughout the state of North Carolina. I am a social worker by trade. I'm not a clinical social worker. I am a program evaluator and a program developer. So I always like to make sure that folks know that, yeah, social work, I do have an MSW, but it's not in clinical studies. I also am the assistant director of fee for service with policy research. So what does that mean? We have a system mapping training center where we offer training through the various program areas that are within the organization. And sometimes organizations and agencies like North Carolina did contracting to come out and train folks. So we're not necessarily getting money from a grant. They might be getting money from a grant, but they contract with us directly to come out and deliver our product. And actually, January of 2024, Tracy Jin and her team had called PRA out to do 2 SIM facilitated trainings. So what does that mean? That means that we came out, our facilitators, bank facilitator trainers came out, and we trained about 50 of our folks that then are now enabled and certified to go out throughout the state of North Carolina to conduct sequential intercept mapping workshops. They're not certified to train other people, but they're trained to conduct the actual workshop that we're going to talk about today. And we're going to talk about how it's important, but most important, why is it important for you all in the room? Why is it important for the collaboration and the engagement for community providers and law enforcement? And when I talk about law enforcement, I'm not just talking about folks, not just the Peace Act folks, but I'm talking about once that initial detention takes place, right? Once you drop them off in the Sally Port, right? And somebody takes custody of those folks in the facility, correctional officers, who's working in the jails, what first appearance looks like, law enforcement within the judicial system as well. So before we get started, I kind of want to read the room. So really quickly, if you can just give me your first name and kind of your agency or what capacity you work in that. All right.
Jack Mountain Guilford and CIT over.
I'm Leslie Olson. I live Ironville from the community education. Part of that is the CIT coordinator and
Which now here I'm the president of Miami Justice County, most of the, Justice Center.
Full voice of the patient peer support specialist, CIT.
Tracy Thompson, mom.
Becky.
Bonnie Andrews, I joined police community.
Rachel Jurin, assistant chief of police, Highland Police Department.
I wear two hats here in Greensboro. I'm part of NAMI Guild Credit. I'm on the board of directors for CFP International.
Okay. I'm not on town, I'm on, never, it was great.
Just volunteer now in Charlotte. Don't see that in companies, but it's not just your one. For state community readiness.
I'll go to the community permanent environment.
Assistant director.
Community resource coordinator, the second police department, Joe instructor on the CIT trainer and part of the Iredale team development and trainer.
Okay. Trainer, all right.
Everybody, I'm Tracy. There's a mental health development of disability. And I am also a consultant.
I'm largely concerned with bio, I'm in our development department. Justice is known as all of our crisis. And I'm also, since still here, actually got the opportunity to go to Albany.
Oh, nice.
To do the
Okay,
there.
nice, okay.
Alice Patrick, and this is Archer. Archer certified therapy dog. I'm a former CIT trained officer, was police officer for 8 years and became a licensed clinical social worker. I now created my own private practice back in March to serve first responders and do contracting for wellness services.
Okay, nice. So,
I am a social worker in the civil police department and recently trained in CIT.
okay,
So I'm emergency room RN and close to air transport RN.
okay.
I work with Iredale EMS as a community paramedic.
Okay, nice. Well, it's very nice to meet each and every one of you. Please know that the sequential intercept model was developed for adults who are suffering from mental illness and or substance use that are intersecting with the criminal justice system. So it seems like there's a lot of folks that are in the zero part of the model, and which is a very good thing, because what we try to do is prevent people from penetrating deeper into the criminal justice. All hands, without the folks who are SIM facilitators, how many have heard of the sequential intercept model before? Okay. Excellent. And I'll be calling on, you had participated in one, right? No? Yeah. Yes. I've heard it. You've heard it. Oh, okay. All right. Okay, again, this is our signature product that we call the SIM. And it was developed in 1980. Policy research in 1987. Patty Griffin and Mark Muniz developed this model in 2006. Policy research is now a remote work person first organization, which means that we do not have headquarters. Our headquarters is in Troy, New York, but it's shared workspace. And that is the current building up in Troy, New York. All of our employees are remote across the country. We have several technical assistance centers. So how many of us have heard of GAINS, the GAINS Center for Technical Assistance? We have the 4 technical assistance, which is the SSI, SSDI, outreach, right access and recovery. We also have the SMVF technical assistance, which is service members, veterans, and families. We also have the HHRC, which is the Health and Human Resource Center, which deals with housing. Now, what I would like to point out is a part of our organization is also through the Safety and Justice Challenge. How many have heard of John T. and Patrick D. Parker Foundation? So they had a big bet, which they have done over the course of their foundation. And their big bet was $180 million over the course of 10 years. And they put out grants in 2015 to jurisdictions, which Mecklenburg, right, and Buncombe, I believe, are recipients of the Safety and Justice Challenge. And these grants range from $100,000 to several million. But the big bet is that jail is not the place for people who are having mental health crises and or substance use concerns, especially if their behavior is not criminogenic and it's not a felony charge or a violent charge. So their big bet was, how do we reduce the amount of these folks, this population, these adults, from entering into the jail? Because we know that, number one, when folks who have mental illness and or substance use are booked into your local jail, it's costing you at least 2 times as much money than somebody in the general population. We also know that it's their length of stay tends to increase. Because we don't hook them up to treatment quick enough. Once we identify the person, we've already talked about identifying, right? So once we realize that they need services, then their length of stay increases. And sometimes they decompensate during that length of stay, whether it's catching new charges because they're combative, because they weren't able to take their medicine when they were booked into jail and now they've decompensated, or you have transferred them out on a crisis basis to the local hospital, or whatever the case may be, their length of stay is 2 to 3 times more than somebody who is general population. So what we want to do is prevent. So the Safety and Justice Challenge put applications in, and it is winding. They say it's winding up. This is the last year in which we will be meeting as a group, but there's 10 years of $180 million that has been invested in close to 52 counties across the United States to safely, I'm not talking about not safe, okay? Please don't know, I come with a security background, so it's not so much as we're trying to let everybody out of jail, but we need to be there. We want it to be safely reducing the jail population. Okay, so here we go. So this is the actual model itself. When you look at there are 6 sections, and we call them intercepts. And the intercepts start at 0 and go to 5. We look at intercept 0, and intercept 0 is the opportunity, and I'm glad that there's a lot of people here in this space, that it's an opportunity for folks whoever might be in crisis, whether it's a family member or that person themselves or a professional, what is afforded to you to be able not to pick up the phone and call 911. So when we talk about intercept 0, we're talking about 988, and I saw 988 here. We're talking about 988, calling 988. We're talking about any crisis lines that may be available in your jurisdiction or your county. We're talking about the actual crisis care continuum. Where is this person receiving services, and if they are or if they are not? If you look at the specific lines, when calls, hypothetically, right, when calls come into 988, we're looking for them to hook that person up to the crisis care continuum. But sometimes that doesn't always happen. And sometimes that 988 call needs to generate into a 911 call where 911 is dispatched. Also, 988 has the opportunity to call crisis lines, which are your peer warm lines, right? Which are any type of crisis line that can give folks tangible information when a person is in crisis or a family member. And again, that crisis care continuum, your behavioral and substance use providers. All of these folks are kind of interchanging, meaning that local law enforcement, once they get to the scene, have the opportunity not to put them in the back of the cruiser and take them to the local facility. They have the opportunity to take them to maybe that crisis care continuum as a law enforcement drop-off center. How many have them in your jurisdiction? With a 24-hour, what county are you in? Okay, and then it goes a 24-hour, 7 days a week law enforcement drop-off. And then so people have the opportunity. So what's law enforcement's wait time? Would you say? Okay, excellent. And how long has it been in existence? Okay, nice, nice. So law enforcement has the opportunity to take them to the center, or we have 911 dispatch. Now, when 911 is called, okay? Who's in 911? I saw somebody in 911. Okay. So tell me a little bit about the training. Do you guys get training for mental health and substance use, or every call automatically goes to law a dispatching officer?
With us, usually one. It's more medical issue instead of law enforcement issue, and sometimes it kind of goes back and forth, and sometimes it's both. So sometimes we may find ourselves transporting the individual that's needing help and the officer is for their own safety and whatever other situations will. Sometimes we are able to get them coordinated with somebody else for the crisis care. The majority of the time, unfortunately, right now, it's getting them from off the street into a hospital or off the street into jail, which is not the best.
Yes.
The only thing in our jurisdiction that we have right now prior to that training.
Yes.
We do have the CIT, we
Right.
have certification, the EMS, telecommunications, local probation, do through that.
Okay.
And that's pretty much, I mean, I know they have those specialized trainings on their own. That's something that's in our protocol going through the ranks. You have to have the CIT as a leadership, part of your leadership to go on, to get raises, these things along.
911 is critical. And when we're talking about getting them for the actual 1.5 day SIM workshop, they have to be in the room, okay? Because a lot of times jurisdictions, there's not very many requirements to be a 911 operator, right? You have to be 18 and above, maybe a GED or high school diploma, not necessarily a post-secondary education, which is fine. But then what does that organization do to get them up to speed? Because people are calling in with not only violent calls, right? But people in mental health crisis, suicide, ideations of suicidal crises for substance use, right? The 911 agencies that not only train folks, right, in all of those topical areas, but also have the resources to be able to manage calls up to a supervisor, and that supervisor can dispatch specific law enforcement that are trained through CIT, as opposed to sending regular law enforcement officers. Now, not everybody's cut out for CIT, right? Not everybody can do this, right? Right? We have to know our limitations. And police departments and police academies that offer CIT in 40 hours, yes, sometimes it's across the board, it's a part of the post training, but it's not necessarily, we have to understand that not everybody's comfortable with this population. But when you do have the ones that are comfortable, those are the ones that you kind of do those wraparound services for and keep them from burning out. So when 911 calls local law enforcement, they have no other opportunity but to bring them to the local facility. That's when they're handing them over to the sheriff. I didn't hear anybody from any of the sheriff's offices, right? Sheriff's departments. Okay. So that's when they're handing them over to the sheriff, whether it's the chief jailer or whoever's in charge of booking. You drop them off. Their arresting charge is communicated, right? They strip them down, give them their personal effects. They do their NCIC checks and their FBI checks. But then at that point, what is important to know is if this person is having a mental health crisis, how is that being identified on a formal basis? And that's what we talk about during the SIM. Most counties who have, and a lot of the counties in the Safety and Justice Challenge have implemented, I know Mecklenburg has, the brief jail mental health screen. And so after they have been accepted into the facility, right, somebody, a licensed qualified mental health professional, or even a correctional officer, because it is developed for correction and security personnel, to do this 8-question, right, screening to determine if this person needs further mental health evaluation and or assessment. Why is that important? It's all about timing, right? It's all about timing. As soon as you can identify someone who needs mental health and or substance use, right, is the quicker that we can, number one, go back and reach back into the community to see what they were receiving in the community, and contact providers to, of course, release of information. But then if you have a jail-based provider, that person then can start their process, especially if we're talking about medication management. So identifying folks early on at that initial detention for this population, I'm not talking about everyone, but what is the process in your local jail that all eligible people who should be screened are screened? Because that's going to help you, number one, get them back into the community quicker. And number two, it's going to then set up folks, and I didn't hear anybody from the judiciary, any from the defenders, prosecutors, right now? Okay. It's going to then give that information to first appearance, because there might be diversionary programs through the state attorney's office, through the local prosecutor, or the defender might have a social worker on staff. So it's very important to identify, but more times than not, it doesn't happen. And when are we finding out that the person has a mental health? After 911 has been called, after law enforcement has dropped them off, even though they've written everything in their police report, when do they generally find in Intercept 2 and 3 that there's a mental health crisis?
in jail, having a breakdown.
Having a breakdown. Right, smearing feces, right, spitting in correctional officers' faces, right, they're thinking they're just being combative, but they're actually decompensated, and that's not always the case, and where do they end up? They end up in ISO-SEG. They end up in ISO-SEG, and then it's downhill from there. You all have seen all of the, all across the nation. I'm from Georgia. I worked in Fulton County Jail for many, many years. So that's a prime example of what you don't want. Thank you. I'm going to talk about that. So SAMHSA had launched 988 softly 2 years ago, and it's a 5-year plan. We recognize that it took 50 years to get 911 straight. So we know that it's 988, but we don't have to talk about that. So first appearance, when people are provided with the necessary information to then become eligible for a specialty court. And when I say specialty court, I mean maybe a domestic violence court, or mental, for the purposes of this presentation, mental health court, a DUI court, a co-occurring disorder court. They're referred to the specialty court, and then probably as it relates to what they offer to the specialty court, they can get out of jail. See that arrow? That's going right back into the community. But more than not, folks go from the first appearance back to the jail. Yes. Yeah. So some jurisdictions have IDD, developmental disability courts, but more times they get lumped into the mental health caseload, right? How many times? I was the Georgia Department of Corrections Mental Health Deputy Director for 8 years, and we had just, when I was leaving, we had just started realizing that just because someone is hard of hearing or has intellectual developmental disabilities, they don't necessarily need to be on the mental health case. But everybody gets dumped into the mental health case, right? So we're starting to see that brain injury, traumatic brain injury, acquired brain injury, IDD is really starting to surface. People are recognizing that, and services and resources are being provided for those populations as it relates to special supports. So when they get to jail, right, they end up staying in jail until their next court appearance, right? So while they're in jail, are they receiving services? Are they receiving? We don't know. Are they receiving services? What's the contact standard? Is there any evaluation? You talk about that going to SIM, then they go to dispositional court, so they can either max out, right? Or they could go from dispositional court into prison, and then prison acts either max out of prison and go to parole, or from dispositional court, just go have some type of re-entry that was established as a part of having them released, which is generally probation. On the bottom, and you have copies of these things. These are all jurisdictions that have been able to work on, like St. Louis, Missouri was able to put a law enforcement diversion program that literally slashed our numbers in half as it relates to the bookings into jail. Then here's the treatment court. So treatment courts in the United States currently, as of 2022, So there are 1,729 drug courts for adults, 286 DUI courts. There's a 312 hybrid, co-occurring 69, family drug treatment, veterans treatment, mental health courts. And then, wellness courts, tribal wellness courts and reentry courts. How much of the tribal community is a part of your everyday work? Yeah. Do you come across folks? Or indigenous? Do you treat service provision? How is service provision? A volunteer, okay, good. So you recognize that. Anyone else?
COD.
Co-occurring disorder. So they not only have a mental health issue or diagnoses, but they also have a substance use diagnosis or misuse. Now, when we're talking about, and these are treatment courts throughout the nation, which is the heavy hitter? Where are the most amount of courts throughout the United States? Drug court. Makes sense, right? The adult drug courts. Because why? We have a drug problem. Right. And a lot of times when 911 and law enforcement are called out, right? They might be having a crisis, whether it's overdose, right? And it's so a lot of people with mental illness, what? Self-medicate because they are not in that crisis care continuum. That they're not receiving the appropriate services. So all of these questions that I'm asking you is what your trained facilitators will be asking you as well as they go through each intercept. Generally, it takes about 2 hours to go through intercept 0 and 1. And then after lunch, they kind of do 2 through 5. But it's really important to kind of get you guys prepped as it relates to not only who needs to be in the room, but the type of questions that they'll be asking you. So there's specific healthcare models that talk about reentry. All of these resources are going to be an attachment in your HUVA app. And one big one is the implementation guide for reentry. I'm an advocate that reentry starts at booking, just like when, and what I mean by that is that when somebody comes into jail, how am I getting you out quick? It's the same as the medical model, right? As soon as you go to an emergency room and you get admitted, what's the first thing they're trying to do? Discharge you, right? And we need to take that same mentality into the criminal justice system. How do I get you out? About people who have armed robbery and rape and domestic. I'm not talking about that. I'm talking about your misdemeanors. I'm talking about you. I'm from Long Island, by the way, so if you hear that, right? Yeah. I'm talking about your low-level quality of life offenses. People urinating on the sidewalk, people sleeping outside of the business, and you're constantly picking them up, right? And then you're getting calls and you're picking them up and you're bringing them to jail. They're coming out at first appearance, and 2 days later, you see the same person again, right? I'm talking about those folks who constantly recidivate, who are your most visible persons in your system. And if you have the right continuity of care in the community, you won't be seeing it. So we're talking about these behavioral health providers, right? We did in Augusta, Georgia, we did a research evaluation. And we looked at all the people in the 3-year period who were being admitted into jail. 86% of those people were receiving services from a behavioral health provider. If you're really receiving these, why? Why is that happening? And sometimes people don't want to be called accountable, but that's how you kind of get to see what's really happening. You know, because when we're talking about Medicaid and Medicare and charging insurance companies, you can just check the box and the case notes in the treatment plan and you're getting reimbursed for your services. I'm not saying this happens all the time. But when you have a majority of the people in your facility that are receiving services from a specific provider and they keep getting locked up, there's a problem with that provider. There's a problem with that provider. But higher than, you know, most of our pay rates. But that's important to know. It's very important to know, right?
One question.
Yes.
On the jail thing. You're trying to work at that level, you've got a district attorney, I like to go on board. We've got, the clerk's office on board, we've got, other people within the system on board. But you do not have the sheriff on board for years, and years of attempts. And the program had to have some change, so the verdict, you know, help the system. I'm the federal dollars that came in back, you know, was eligible for every law enforcement officer, two agencies used it, not the sheriff's department. And I know this is not a good, but this is a reality in many counties, because I know there are other counties in the state where that head law enforcement manager daily said, we've got a perfect plan. We had the state come in, we have a reentry process out of there, and get state dollars, but we still have been doing it for 6 years. But we can't get that. We don't have a champion to get the one who oversees the jail to come on board with us. We don't have a position, you know, we don't have the people that have impact. And so that's where we need to help. And I know there are other counties in the state that have a real same issue with this. When COVID came, we were ready. We were 2 weeks away from starting this process. Through partners behavior, and it got somebody on board for this. Under our opinion group, the VA and everybody on board. We couldn't, COVID shut everything down, we still didn't have that eyes law enforcement on our side.
Yeah, it's good.
So, you know, we gotta have that.
What's in it for them?
We've got to have.
That's what you have. What's in it for them? Would that mean that I could get more money in the budget? Now I can reinvest the money that we're saving on a jailhouse provider? Almost $30 million a year to a private provider. You can even slash that in half. Then you're talking about more money for your correction officers, right? You're talking about incentives for retention. So you have to find out what's in it for them. And you get that by seeing what's their pain point. What hurts you the most, Jared? And then and I've seen it happen, you work around, they might not be signed up, but when it's about nobody wants a correction officers hurt. Nobody wants not a 26% vacancy rate. Nobody wants people not coming to work. You can train them, you can recruit them, you can train them, but retaining them is a whole different ballgame. And then you get people overworked, people start taking in contraband, right? To kind of fill in the gap. Reality. That's reality. So what's in it for them? And what's your pain point? Because we're all on the same page and we all we're charged with the same folks. We all want to be in a way that we're providing services more effectively and doing the right thing. All right. So with this population, you've got complex health needs, not only mental health and substance use, but primary health. A lot of folks who are coming into the jail system have, you know, comorbidity. They've got diabetes, they've got high blood pressure, some might have cancer, you know, respiratory issues, like we talk about brain injury and IBD and other disabilities. Let's talk about the prevalence, and I know I'm preaching to the choir. So general population, me and you, right here, outside the wire. 6% of the general population have a serious mental illness, all right? When I talk about general population in this slide, it doesn't mean general population. 17% of those in jail have an SMI. Diagnosed SMI. Out of the 17%, 76 of those with the SMI have a co-occurring disease. So something's going on. They're on drugs for whatever reason that may be. Right? So when we're looking at 6% of the general population, but then when you're getting in jail or prison, it's 17% of those have an SMI. We also want to take into consideration trauma, right? Trauma in the justice system. This is a very, very old study, but there hasn't been one out since then. But when people think of trauma, they kind of think two genders, right? And men don't have trauma, right? Yeah, right? They're like, all women, we're all hysterical. right? So out of a lifetime. The study revealed that 95% of females said that in their lifetime, they've had a traumatic event or an experience that altered their life. 86.6% of males. When the study happens currently, the females of the 73, almost 74% of females said that currently they were experiencing trauma. But 86.1% of the males said that they were currently experiencing a traumatic event. So trauma is across the board, whether it's physical or sexual. Know that when we're looking at men and women, know that there is no difference as it relates to the rate of trauma that people go through, right? It's across the board. So high prevalence of SUD and trauma in jails. So with this study, and all the references are on the bottom of the slide, but 80% of the arrestees tested positive for any type of drug. All right, and 63% of jail inmates have a substance use disorder. Right? Meaning that 41% are only with SUD and 22% have a COD, which is a what? Co-occurring disorder. But what's startling is that only 1 out of 5 receive drug treatment while incarcerated. How many of your jurisdictions have MAT services in jail? And does it offer them, is it inception, or if they can prove that they were receiving it in the community, then you continue it? Do you start it? How does it work? Okay. Who else? Raise their hand. Have MAT, yes. Is it, do you offer it?
I'm not in the jail, just know we have it.
Okay. Yes.
Just been drawn.
All right, and that's if you can prove that you're receiving that from the community, or does it start? Yeah.
And then start.
Okay, excellent, excellent, excellent. Has it changed things?
Yes.
Yeah. How?
More are receptive to it, more wants help when it's in the jail.
Mhm.
And we're trying to allow others to do it.
Yeah, it's very, very difficult to have leaders though bring in controlled substances. It just goes against the whole paradigm. But when you see the data of how MAT services really works towards a person's recovery once they re-enter the community, it kind of flips the script for folks. And it cuts down on contraband too. Cuts down on contraband, cuts down on weight.
What are you saying? You're using some term now, and what is a MAT service?
Medication assisted treatment. Meaning that if I'm in the community and I have a heroin problem and I'm getting methadone in the community, I'm getting enough heroin, that when I go to jail, I'm not going to stop. They're giving me medication. What's called MAT, medication assisted treatment. A lot of jails don't offer that. Most jails don't offer it because it's a controlled substance in which they feel that it's just a substitution for their drug addiction. And then that's changing the philosophy of a lot of folks. Okay? Whether it's right, wrong, or indifferent, it works. All right. So I won't get too much into this slide, but it's a medical and disability challenges of state prisoners. The only reason why it's in here is because what happens when somebody goes on parole and they get revocated? Where do they end up? They go back to prison? They go back to the local jail, right? So the parole officer realizes that they're there, right? And they got to go to court, XYZ. That takes time. So it's important to know some of the statistics as it relates to state prisoners. And the cognitive disabilities are the greatest among state prisoners, which is just to me very outstanding. That 19.5% of folks who had a disability in the state and federal prisons, it was listed as cognitive, which goes back to that IDD question. So how do we, what's the magic wand, right? How do we kind of solve some of these societal woes? It's all about collaboration. It's not like those who you're working in the law enforcement and you're working in behavioral health and you're working in the jail, you're all working with the same person, right? It's not different people. You don't have different caseloads. It's the same folks that are being passed along that intersect, right? And you have a part in that system. And so how do we make sure that services are provided in a way that's factual, in a way that is timely, in a way that meets the need? It's through collaboration, improved integrated services by promoting collaboration. During the Sequential Intercept Model workshop, you're going to have people from Intercept 0 through 5 at the table. And as they start asking questions and they start giving answers, you're going to start learning about the services that they provide. It's going to be such an aha moment, like, wow, I didn't know that that was available. I didn't know that you were the person who does that. And the networking that takes place is invaluable, right? Because now things that have been caught in the system, that something as simple as who got arrested yesterday and getting that to the first appearance clerk, right? So that they can go through the list so people don't have continuances are taken care of by sending out an email in the room. You know, and I don't want to be too minimal, but a lot of connections start happening within the Sequential Intercept Model workshop, and people start meeting other folks behind that email address, and collaboration starts taking place. So we talked about the Safety and Justice Challenge. All those dots are where there are counties, or if there's an innovation county, they've received every year a grant for at least $100,000. If it is a implementation site, which Mecklenburg is, they've received millions of dollars. And it's generally going through the local sheriff's office or the CJCC. But through the MacArthur Fund, San Francisco was able to cut jail usage by nearly a third, and they shuttered a jail that was considered inhumane by the Policy Prison Initiative. I believe it was Pew, and they shut that jail for good. And then we talk about 40% in Philadelphia, 27% in Charleston, 30% in Cook County. But there is the link where you can go in and read about some of the efforts that these local jails were able to safely reduce their jail population. Mecklenburg County, Buncombe, who's here? Who's here from Buncombe? Are you, okay, are you involved in any of the efforts to the SJC? Okay, that's fair. So Buncombe County was able to also, they have specific strategies. They have community engagement. They're working with the courts through the grants, data analysis, diversion, pretrial services, and racial and ethnic disparity work. Mecklenburg County, I know Chris Peters. I believe he is presenting tomorrow on Mecklenburg, right? They had a sim, and through their sim, they just turned everything upside down, right? They had it way back when, not through, they got it through PRA, but PRA is a technical assistance provided through MacArthur and Safety. So when any of those counties asked us to come out and do a sim, we came out and did a sim from 2015 even to this year, 2025. A lot of them are doing redos. So Mecklenburg County, I believe, got a sim back in 2016 or 2017, and they have just run with it. They had a redo, I think, in 2019, and they're going to talk about that tomorrow. If you can get to Chris's presentation, he's going to really show you how the sim process really advanced the work, kept people together, kept people collaborated, and showed the importance of that type of work as it relates to this population. Another effort of collaboration is Stepping Up. How many have heard of Stepping Up? Should be everyone, because I was looking up the stats. North Carolina has 100 counties, right? 47 counties are Stepping Up counties. That's half the state. So I expect to see like half here. But yeah, Stepping Up. It's an initiative that county leaders sign a resolution, and that resolution says that they are going to implement 6 goals of the Stepping Up initiative. It's through NACO, it's through the American Psychiatric Association, and it's through the Council of State Government. And it's reducing the amount of people who are mentally within jail. Primary is reducing the amount of times that 911 is called. Shorten, and then if they can't reduce the amount of times 911 is called, is shortening their length of stay once they are arrested. Once that they are in there and they know that they have mental illness or substance use, how do we connect them to treatment while they are in jail? And sometimes jails don't have behavioral health providers or substance use providers. But then what do we do for in-reach? Are sheriffs willing to have community providers come in and provide those services? Okay, yes. Yeah, it's settingup.org. You'll see that on one of the, when you download this, app, when you download this on the app, go to settingup.org, I believe it, and I'll tell you. It has to do, yeah. And then once they are arrested, how do we shorten their length of stay? We increase them to treatment, and then we reduce recidivism. Those are the 4 main goals. So there's 47 counties in North Carolina that have signed up for setting up. I'm talking your county legislators have signed these resolutions. It's been a county proclamation. And you can go to step up together, the counties, and then that North Carolina. So SIM is a conceptual framework. And when we say a conceptual framework, it means that you're considering the interface between criminal justice and behavioral health systems, and it's a tool. It's a tool in which communities use to be able to see not only what the services are in each specific community, who's doing those services, who's accessing those services, and what some of the gaps are in the service. Generally, when we have a SIM model workshop, it's imperative to invite people who access services. And I'm not saying that you gotta have 5, 10 people there, but at least 1 or 2 people who are a peer or a family member of a peer. Because generally, every single time, I haven't seen it when it hasn't happened. When people start saying, well, we are such and such an agency, and this is what we do, and this is the eligibility criteria, and this is what we provide, X, Y, Z, they'll be like, that wasn't my experience, right? So then we want to be able to provide a transparent and open, right, discussion of what happened to that family. Because if that happened to one person, safe to say that perhaps there's other people who didn't receive the services that the executive directors think is aligned with the mission statement, right? So when you have a SIM, you have to have the folks who are the decision makers in the room, your mid-level managers, but also the people who are doing the work. So then the people who, the direct service workers who don't necessarily have a day-to-day with their executive organization and agency heads, right? They can hear what's going on in the field. But the peers, the family members are important because they bring transparency. But you have to make sure that the person that you identify to be a part of the SIM has the ability to communicate, not communicate effectively, but doesn't kind of turn people off, right? And doesn't have fearfulness of law enforcement being there. You've got to do some prep, all right? But their testimony is invaluable. It's invaluable. So it's an organizing tool. And then when we start going through each intercept and we ask specific questions, we start identifying the specific gaps. And then those specific gaps then start to resonate that if we really were as a task force, as a community, as an organization, looking at these specific gaps, and we put all of our efforts towards it, then we'll be able to close the gap and move the work forward. Yeah.
Intercept what?
Sequential intercept. So, they always start off with this elephant. It's been around for a while. So you ever hear the fable the fable of 5 blind men and an elephant came into the village? How many have heard of that? Oh, nice. Okay, good. And so they are asked to describe the elephant. And then one guy pulled on the tail. He said it felt like a rope. One guy pulled on the trunk. He said it was hard and rough. And one guy touched the ears and they were, floppy, soft. And one guy touched the legs. And so at the end, they had 5 different descriptions of this elephant, but it was the same elephant. So everybody was more confused than when they started. And that's kind of the same with all of the partners in the system, in the judicial system. That people who are arrested may not know what's going on in prison. And the people in prison may not know what the community services are. And the community service supervision and services might not know exactly what's going on with substance use. All right, so all of these play a part in your system when you do a SIM. And when you're invited to the SIM, everybody who's representing each one of these areas will have an opportunity to share the services and parts of their system. Mental health, substance use, court, screen entry, prison, initial hearings, jail, community supervision, and the community. Here's another point of the map. Let me see a show of hands as it relates to what part of this, do you know what part of the system you are? You were to go to a SIM tomorrow. What intercept would you fall on? 0. 1, okay? 1, 4, right. Anybody not know where they would fall? Yes.
So I work for work camera reduction coalition. So I can follow along the lines of a lot of these, but on the advocacy, technical assistance, and provider.
Okay, so the community then, would you think? So do you provide services inside different local jails?
It's
Okay, and then do you provide services to treatment courts?
currently we're working.
Okay, so it looks like you're touching every part of the system. Yeah, at least 0. You don't have any really interface with 1, but then you pick it up. You pick it up, right, on specialty courts. And then probably community corrections, right? Because if a part of somebody's probation is to receive services, you would be able to provide services to people who are probationers.
Great, oh, yes.
Okay.
Probation.
Anyone else not know where they fall? Yes.
Hello, I'm with the Autism Society, so I'm thinking of community services.
Okay.
So we don't go to jail, we're on like parents with policies that are not adult.
Mm-hmm.
It's arrested and we don't know what to do.
Right. Right. Yeah, probably 0.
Follow them in.
Okay. All right. Yeah, I would say 0. Because if you look on the back of 5, that's community as well. A lot of times, nobody's from probation and parole in here, right? They're very important to have at the table as well, right? Especially when people are not maxing out, but they are conditions of parole or conditions of probation. Especially when it relates to receiving services, and those services are directly aligned with them going back to jail or prison. Yes.
I'm curious, in all reality, is there any bail bonds from agents and himself?
5 and 0. Yeah, absolutely. 5 and 0. Now, we hear from a lot of probation officers that, sometimes, they've never met the person, right? And that they have to have XYZ services and they live here and the services are here, right? And it's just so very, very hard to be able to make it work so that person does not. And some of those conversations need to get flushed out for the youth facilitators who are in here in 5, because they're real concerns. And sometimes when we get so involved in 0 and 1 and trying to stop people from penetrating the system further, we run out of time to work with Intercept 5, but I encourage those who are facilitators to really make a point to give them the time that is due. Yes.
From personal experience, when it comes to state probation and federal probation seems a little bit more knowledgeable about the local resources, where state probation, I don't even know if they have the capacity to. They're very loaded with.
Interesting. It's very interesting. Okay. So we've gone through this. Intercept 0 is 988. Your crisis lines, what crisis, can anybody tell me any of your crisis lines that you have? Okay, good,
mental health care support, warm line.
okay. Here's the, and what services, also here, answers phones, and 24/7? Yeah, okay,
We can never use a loan.
Yeah. Never use a loan line?
Yes.
Okay, what is
Where if
that?
an individual is about to use, they can call this phone number and an individual will stay in line with them. And if they become unresponsive, they will call EMS and get the location where that's going to be.
Okay, I want to come back to TV. So is it open 24/7? Okay,
Officers making a duty call, a modality assessment,
okay,
and officers can call from on the scene.
oh, nice.
And, it's a national model, the modality, of course, it takes the box with us. And then in the legal situation, they're automatically connected to the law, which can start the process going to a safe place, connecting them to the next day, and not get the expert pay and so on and so forth.
So law enforcement are the only ones who can access that? Okay,
I'm just saying that's the way our agency does this. But no, it's open to the public. And you do not have to be, it's the shelter, the food, the definition of sexual assault and domestic violence. You do not have to be a resident to gain access to counseling and their resources and their.
so in a sim workshop, you will come in and there'll be large easel sheets all over the walls. And those easel sheets will represent each intercept. And as people are sharing information for every part that the facilitator is asking, they then start inventorying and capturing that information. Okay, so that at the end of the workshop, the day and a half, you will have a whole wall full of all of the information that everybody shared. So here we go with 988. So in 988, SAMHSA, the federal government had a 5-year vision for 988. It was soft launched in 2023, meaning that 90% of all 988 contacts answered in state. A lot of people move. I still have a 631 number and I've been in Georgia for 18 years. So what would happen before my 631, if I was to call 911, it was going to Port Jefferson, right? Because it's 631. But now with 988, they're collating and making sure that all, not just part of it, all of the calls are being answered in state. Another one of it is to the Horizon, the crisis contact center. So there's now crisis contact centers that are responsible for answering the 988 calls. Who does 988? Here, I heard something. Yes, okay, tell me a little bit about 988. In your account, how the calls routed, and where did it go?
Well, I can talk about it.
That's fine.
So, they watch the video on the single state. So, geo routing was by South functional just suicidal. We got that call soon after the which allowed that one state in the state. And it's on to that happened prior to last. I don't know exactly.
Yes.
I just have a question because I can't hear too well over here. But did you say that 988 now does geo location or routing?
Geo routing.
Okay, thank you.
Yes.
So I know just enough about 988 is run by the district fire department.
911. Okay.
What? A little bit loud.
Yeah, so there is information outside on the table about 988 in North Carolina. And after a certain amount of time, it'll automatically go to 911. But remember, we don't want folks to penetrate into the criminal justice system. So 988 is a resource for communities to call when people are in crises, as opposed to calling 911. So I've got a family member who, their son is having a mental health breakdown. I don't want him locked up, but now I'm calling 988. 988 is someone to talk to, someone to respond, and a place for help.
And they have to.
Yes, they do.
I just want to 988. It doesn't, by a certain amount of time. They can insert it in state, it goes to national, it will get rerouted to another.
Okay. Did you hear that? Not yet.
Question, because we work with juvenile, and I looked at a program is minded and also that, for someone to call for someone to which we found out.
So part of this 5-year plan is for jurisdictions to share with local communities about the education of 988 that is available to them versus 911. Yes.
One thing I will say is, 988, we had hoped we would be able to integrate that somehow with 911.
Yes.
That has not really happened, and a lot of that is on the state side.
Yes.
Within our legislature and some other things, there's a lot of rules and a lot of the powers that be that are over 911 telecommunications don't want to see that happen for some reason or have not been receptive to it. And I think if we could somehow work together a little bit better to make that happen, because a lot of the law enforcement agencies are now going to, and we're in the process of trying to implement this ourselves, is like alternate response models where we use clinician teams or
Right.
crisis counselors. The first level in that model should be 988 because it's a resource that's there that takes law enforcement out of it altogether.
Right.
So they would stay at 0 before they move to that number 1 intercept and call 911
Exactly.
or our non-emergency number. So we've tried to do an awareness campaign to get people to, so many people, I did a presentation 2 days ago asking me people in the room knew about 988, like one person raised their
Right.
hand out of 30. So we're still trying to push awareness about it. It's an outstanding service, but I think we've got to do better about learning how to integrate those
Yeah. What's
services.
available. And it's not uncommon. A lot of states are struggling with getting the word out. And like I said, it was a soft launch to the federal government in 2023. They're gonna ramp up services, hopefully the money's there, but the end goal is 2027 to have it fully operational and every single person knows, just like you know about 911, you know about 988. Okay. Here to
The success we have had with 988, 10 million countries, 10 million calls at reception. That was July of last year. We've 190,000 responses in terms of having response to visitors for the system. But most of the calls were able to be connected to the community behaviors that we have. So it is building more.
So it went back into the community and not back, we didn't have to call 911.
Correct.
Do we know if other states, if 911 has permission to transfer to 988 in other states?
Right here. Okay. So if you're out of Texas. So that's one question. And that has gone through credit line. And so who sends that, but no, we haven't yet, and they'll be back in the back.
Just to, whoever asked that question from the front, it is a national best practice standard to be able to divert a call from 911 to 988. In fact, Tina has operability. We have found in West Virginia, we've got 55 counties that include 51 sites. They all independently operate in both states out of independent lands, not one governing body. So we're making those connections PSAP by PSAP. So we probably out of 51 PSAPs have about 3 that have signed it. They could all would not fit into it.
See what's going on? Yes.
I just have a question more about, quite frankly, marketing on it. In other states, I know in certain parts of North Carolina, we don't mind it awards. I don't know if that's a state road, highway kind of thing, but I'm also wondering about in other states, other than I just think that's also a great way for traveling to see those awards. And in Mecklenburg County, we have 988 awards. So I'd be interested to see that could be something potentially to the state.
Ambulance is great. When we go out to the community in North Carolina, our average answer rate is in 17 seconds. And we try to tell people that you can call for any reason and you can call for somebody else. And I think that the word crisis makes people feel like you have to be suicidal or you have to be in a psychotic break. But the reality is that the system is, the way we understand it, the system is designed to avoid someone getting to that place. So, you can be a loved one and call because your loved one can't get their medications and you need resources for that. And it can be crisis. And it's probably this way in all the states, but the Trevor line is part of that. The veterans, there's an option for that for young adults. And there are different levels of educated support people. So if somebody's needing for resources, versus someone who's in serious crisis. So it is a tremendous resource that, and even when we go places and they've heard about 988, they don't know how to use 988. Or they don't feel like they have the permission, if somebody has to be already created self-harm for themselves before they feel like that number.
And education is key, college education. And when you talked about, someone asked about how is it being distributed, it's whatever state agency took on the ownership of 988. And however they have made determinations and what their strategic action plan was to roll it out. I know with Georgia, it was the Department of Behavioral Health and Disabilities. They own not the rollout and the implementation rollout of 988 across all 159 counties.
Yeah, I will say there's a huge community of individuals that are not utilizing.
You heard it right here.
And they also aren't in contact with, this or that, there's a lack of trust with our systems. So I think we need
About public education. Now, I don't know who owns or who holds the rollout of 988 in North Carolina, but that would be helpful, to know that. Yes. Okay, there you go.
It's part of the strategic.
Can you say that a little louder?
It's part of it's out of the Division of Mental Health Development and Disabilities and Services. Lisa Chance was going to present tomorrow, but wasn't going to do it today. But we do have the table, it's also part of our strategic plan specific.
Thank you. We're going to take a break at 2:30, so I keep looking at my clock. So give me about 20 more minutes to get through the more slide. So the crisis and stabilization care continuum consists of your 911, 988 integration. I won't read them all. ER diversion and peer support navigators, your crisis residential, your crisis respite, your transitional residential, your peer respite, and that's your crisis and stabilization care. You want to make a healthy community has one or more of these available. 3 to 5, pretty good. 5 to 7, best practice. So then you can meet the needs of everybody who comes through that. And crisis doesn't not necessarily mean that like Becky said, that person is completely having a mental breakdown. There are other resources that they are in need of. Integrated care is vital. How many of your jurisdictions have CCBHCs? And one, all right. How about a FQHC? Okay. So these are medical clinics, right, that provide comprehensive services in mental health and substance use. They serve everybody regardless of their age, their gender, diagnosis, insurance. FQHCs are federally funded. They're usually on a sliding scale basis. These are the requirements of a local community behavioral health clinic. They've got to have crisis services available, screening and diagnostic services, risk assessment, psychiatric rehab, outpatient primary care screening, peer support, community support, outpatient medicine. So you see, if you have all of these in the community available to somebody who is receiving a mental health or substance use concern, how if the community is built up with these types of services, that 911 may not be called. Yeah. Enforcement and emergency services. So now 911 is called, right? So how are they sending folks out? Some folks, some jurisdictions have CIT teams. CIT is always foremost a community partnership. It has 40 hours of training and it's accessible through responsive crisis care. I saw a few people with CIT. Yes, okay. So CIT is very important, especially for 911. So would you say that your 911 operators in your specific jurisdiction know that there's a CIT team that they can dispatch? They do now. What do you mean by that?
It took us a while, Johnson County, why we actually got the 911 operators actually involved in the CIT program.
Okay.
So that way when you call in, I go after the new CIT center, or new 911 center, down from my house. So I get a lot of people who come in, and it took us maybe 3 years before they finally agreed to do it. And now, yeah, it's been a huge.
Okay, nice.
And there are, it is difficult to get into certain areas when it comes to CIT or certain of the providers, via Trillium. It's been difficult to get into certain areas or regions due to lack of education, stigma.
Okay. All right. And what's being done to kind of?
Oh,
okay. So you also might have the co-responder model available for law enforcement, where there's a mental health professional employed or working alongside the police department. Any co-responder models working in any of your jurisdictions? Good. Excellent. How's it going? Co-responder. It's a progress. Okay, good. Is it fully staffed all the time?
Yeah.
No. Does that impede?
That's the work in progress.
That's okay. It's hard, behavioral health and workforce development. It's tough, especially with telehealth. And telehealth is a blessing and a curse, right? Before, when they said they couldn't do it, when we needed it, and now that's all that folks want to do. Yes.
It was a little bit. So I was actually on the co-response team in Charlotte, and was the leader of the team and developed the program in Davidson as well. And so different models work for different areas.
Yes.
It's not a one size fits all model.
Mhm.
And one of the issues that we had is even cultural competency with the clinicians trying to jump into a patrol car for 10 hours with a cop.
Right.
That's different when you're talking mental health providers. And that was one of the challenges that we saw with some of our people.
Okay. Yeah. Nice. Off-site support, so telephone support to on-scene officers, video-based virtual crisis response, and specialized EMS. I saw EMS here. Yes, you have specialized EMS where it's co-response with the mental health clinician. You go there and law enforcement meet you as well.
Usually what happens was, And, law enforcement has done before, it's saying when we go in, trying to determine, is this gonna be somebody that wants to hospital? Is this somebody that wants to go with this? Or is this something that, legal law enforcement or vice versa?
Okay.
So that's about as far as we are in there.
Got it.
And there's sometimes that
That hour.
sometimes the calls happen.
And they call you to meet them.
Yes, we got
What you're responding with.
Mhm.
Or what they're asking.
Okay.
It's a non-formalized.
Nice.
Right.
That's good. Sometimes that's the best type of relationship.
And other community resources we've had to find ourselves as community. residents. And sometimes that might involve finding somebody important towards as somebody that's more geared in spiritual care, because that's part of what you're looking for in that, or somebody that needs the mental health clinician and trying to point them in the right direction. And so it can be a challenge sometimes, and trying to do it with somebody that's also quiet is also a challenge. And then it's really frustrating when you have somebody that has a critical mental health crisis and you get them into a hospital and then 3 hours later they're back on the street.
That's the biggest thing right there.
And that can be
It's
a
like
challenge.
those that-
I'm looking at the hospital person over here.
And I'm not saying anything against.
Oh, yeah, I know. Right?
Legal aspects. of it.
We're in the process of trying to, we've had a meeting with our, providers, in the process of trying to figure it out.
You had a question.
Oh, I was just gonna ask.
We got the peer support team that works with substance
That's
abuse. Yes.
That works hand in hand.
That work meeting now.
It's depending on who it is. Sometimes more of us, see people that do
Non-traditional work.
Okay. So for the facilitators who are in the room, when you're inviting folks, your hospital people need to be there. Just for the specific reason of what he just said. That they're thinking that they're gonna hold them, maybe, give them a psych hold, 24-hour hold, but 3 hours later, they're back with things. So hospital people have a lot to say about their most visible persons, that old term, which is not politically correct anymore, frequent flyers, right? We call them MVPs now, but you're gonna want to hear from your hospital people, especially about those folks who are coming through their doors with psychiatric and substance use concerns. All right, we talked a little bit about the behavioral workforce shortage. We know that 75% of all counties are mental health shortage areas, and half of all US counties have no mental health professionals at all. None. What do you guys think that there's a reason why folks aren't either not going into the field or not staying in the area? Yeah. Hey, okay. Burnout, stress, lack of support. Yeah. So how is reciprocity? Do you use that with people like your state licensing board? I'm able to use people who are in Nevada that can provide maybe telehealth services. What's that licensing reciprocity with North Carolina? There is none?
So for social work, they're working on an interstate compact, but now each clinician has to be independently licensed in each state they're providing services.
Wow.
So
Okay.
it's very.
So we've got issues with safety, law enforcement knows, and everybody in this space knows that the behavioral workforce shortage, along with response time, is going to make somebody what? Take them to jail.
Also, when individuals are using opiates, they may be less likely to accept resources because they're not sure if they're going to be continued or if they're going to be provided treatment. So that they don't facilitate the trouble.
That is also valid. So you've got to let sheriffs, not only sheriffs, but people on the one end line, law enforcement. Why do I want to reach back to the community? you know, on that slide where those arrows go back into the community, what's the incentive not to just automatically transport them to the local jail?
To build, yeah, on the flip side, it's a revenue.
Well,
Well, I know
let's,
in our CMT.
Yeah.
When you talk about what costs to keep somebody in jail. what-
yes,
That's when
Yeah.
you start getting binded.
having the accountability leaders there too, and having raw data. Raw data. But raw data comes from identifying people early on. And then when you identify them early on in that initial booking process, then those are the people who are gonna get ported over to the caseload. So I'm a WellPath employee, out of my 800 people, 776 of them are receiving psychotropic medication, which is costing you XYZ. It's the data and taking the time, which interns are great for that. Let's take a 15-minute break. We'll be back at 2:35.
In the official CIT. I'm so sorry. Oh, I can.
got last meeting. Hard.
Where did they put, did you want this?
Oh, thank you. Okay. Okay. No, I'm learning. Do like they're sad how they are. To be able to respond to if they do. Okay. Okay, so, and I'm. As you're talking, because they could essentially have to be, you know, very bad. Right, been doing this for 19 years. So very familiar with like all of the logistics of what although I can and one may not have, or they might be on the phone already. So I'm trying to visualize like they have like one another. Okay, so Matthew was a little worried about, is there a document that you can share with me? Because that is so, okay. Yeah. I understand that. What's the focus of that particular? Do you know? I wouldn't know mine, so I think his last name is Raj. Yes, so I'm honestly, we applied. We expressed ideas, but we have not been awarded the contract, so it all has worked out, and I'm like, I think that they early to make sure I got here, to make sure, because this was gonna be a great network. So if you can get that connection with Sheriff, I was. Okay. Okay. All right. And once again about police chief and everybody there, but I know the leader has to fight in order for it to, I got you. Okay.
Grab one leg, I grab the other. So now.
Okay.
Just to work first.
Together, not working in silos. Right. Yes. So I'm familiar with, what the intention. So
definitely partnership with schools, our kids too. And it's telling that if it's a school in the city, they typically respond. Okay, but you also have schools that's within the. Okay. 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 All right. If a proposal needs to be made to be part, is there a specific number that they use? So they get their referrals from
Because right now that seems.
I was talking about, you actually took it. Yeah.
Yeah, ours, the ones who have those. That. Yeah. Okay. Okay.
Files out.
Okay. So you actually, so I'm, however, the breaker of, but for projects like memory communication. Full-time staff and. Okay.
Give me correspondence. You did better. I did.
She has salmon food, I put lamb in it. Because this is all the stuff that we need to figure out. Seems like, yeah, right. Okay. And I'll make sure, I gotta put some different parts, and I'll. That's a number to reach. Okay. But yeah, we're trying. Fine. Fine.
I'm sorry, I'm just chatting.
No, I left your message.
Okay.
Because I know you're just a bubble. Yes, and you're coming to do the, yes, so I knew when she said that, I was like, I know you're gonna hook up with her and get that information. This, it's really important.
The three.
Started. And then at 4:30.
take over and kind of share a little bit about how, sequential intercept active workshop are gonna roll out in North Carolina. So we spent a lot of time on intercept now and intercept one, and you see that there's a lot to go on in that community in 1.0 and 1. And we didn't even touch on hospitals, right? So when you're invited to a sim workshop, know that a lot of the conversation is gonna be in 0 and 1. That we need to hear all of the services, the warm lines, everything that's available to people who can not have to pick up the call and dial 911. But it happens, 911 is there, we might not have CIT, we might not have co-response, we might not have specialized EMS, and 911 is called, and then they make the decision to call law enforcement is involved, again, the arrow go back into the community. But let's talk a little bit about step one and that arrest. This is right? So this is from the County of Los Angeles and Broome County. They were able, through a sequential intercept mapping workshop, develop specific 911 triage tools. And with these triage tools, they were able to train 911 operators as it relates to specific calls. Once they reported for mental health crisis, and then that's decisions, right? And then they make decisions with all the supervisor to be able to determine if this law enforcement could be dispatched for specific co-responding to be dispatched, or if it can go back into 988. So these are some of the tools that are developed through the workshop that you will be involved in. It doesn't necessarily need to be a 911 triage tool, but if that's what the community feels is an important priority for getting the work along and addressing these situations, that's what they do. Now, all of day one is the model workshop inventory, like I'm asking you questions and where you're sharing about your community. On day two is strategic action planning. So at the end of the day, everybody in the room kind of comes up with about 20 different priorities for call. And then we feel that these 20 things are the most important gaps in our system. And then everybody in the room gets to vote. And whichever gaps have the most votes, everybody gets 3 votes apiece. Whatever has the most votes, those are what are used for strategic action planning on day 2. So in Los Angeles, the County of Los Angeles, developing a 911 triage tool came up as a priority, so that they took what the framework on day 2 of what it would take, and then in the following months, 3, 6, 10 months, they developed a specific tool. So it's just not a day and a half coming and, eat good food, and just getting, having 50 million emails when you get back. But there's work that needs to get done, and we're all here to advance the cause. But there are also targeted diversion opportunities for nuanced populations, like we've heard of LEAD, right? Law enforcement, diversion, human trafficking diversion. So these are targeted diversions that help law enforcement make decisions not to take them to the local jail. Some communities have opioid diversion, homeless diversion. A lot of communities have CAT teams where 911 does get on the scene, but they can call CAT, and then the homeless diversion comes over, and as long as they know that their prison is safe and has somewhere to go, law enforcement then leads on to the next call. And then there's pre-booking diversion, meaning that once they do sometimes it happens inside the precinct, but sometimes there's diversion to treatment before they accept them into the facility. Once they know, but that's about early identification. There's also a citation or disappearance tickets. Anybody know if any of that is distributed in any of your jurisdictions? That have, and let them be booked into the facility, they give a disappearance ticket. And that's another way of having diversion without them being officially booked or in jail. So there's ways to be diverted and not penetrate further into the system. It generally really, has to do with what your jurisdiction needs and who your folks are. So intercept 2 is really a very quick intercept. We talked about initial detention a little bit. Initial detention is gonna be when you guys have left and you hand them over to the jail administrator and they do that initial booking process. And there's usually 6, 8, 10 steps to initial booking, right? After they kind of make sure that they don't have any weapons and they take away their personal property and they do their national and their statewide screenings. They might have pretrial services as a part of your initial booking process, fingerprinting, taking pictures. So it's kind of like an assembly line, right? How many have gone through like an initial booking process? Not meaning like you were booked, right?
I have.
Yeah, so can you describe it? Have you been through it? You know all the steps?
It's been a while.
So if you have the opportunity, it's always helpful to see what those steps are, right? Especially if you're working with these folks. And then initial detention also is about that, remember, that identification of folks with IDD or substance use or mental health. And then initial, intercept 2 is their initial first court appearance, which is generally 24, 48, 72 hours max. 87% of jails are owned by county, okay? 87% of jails in the United States are owned by counties. 67% of the people inside jail are pre-trial, all right? When we talk about pre-trial, that means they're waiting to see a judge. They're waiting for a disposition of what they were being accused of committing. 40% use a risk assessment. Risk assessment was developed in order to what? Let people out on bail. What is your risk of a failure to appear if I let you out tomorrow? Only 40% of jails use a risk assessment and 60% of the jail population are considered low risk. Low risk meaning your quality of life crimes that we talked about earlier. Right?
60% of the actual population
Is pre-trial, is
40.
Yeah, so that's important because I know it's this old study, but it's like, again, it's one of the only ones out there. Kentucky did a study on low risk defendants and to see if they were likely to commit crimes before trial. And they showed that even with 2 to 3 days of holding somebody who was low risk, increases their likelihood of committing new crimes. So detention of low and moderate risk offenders increase their rates of new crimes. Anybody talk about that? There's 2 sides to that point.
Yeah, I will say, well, if you're not incarcerated, opportunity to make decisions whether to utilize treatment or community resources. You can get counsel that can guide you as to what would be best for you to do so that you can not only reduce the risk of incarceration when you do the work, but reduce, which also would reduce the likelihood.
Right. Also with, yes, go ahead. Absolutely. Yeah, it stabilizes everything, especially with women with young children, right? And if they don't have a plan for a kinship home, then the state comes in and has to put them in emergency foster care, people lose their jobs.
Yeah.
Yes.
I would even say.
Yeah, it's a traumatic experience. Absolutely. Absolutely. So bail reform, is there bail? There's no bail reform in North Carolina, right?
No.
And the advocates on both sides, right? Some people feel like no cash bail doesn't work. Some people are advocates of it, but many people who are detained pre-trial is because they can't pay to get out.
There's people locked up for misdemeanors that end up losing their jobs.
Everything. And then, you know, we've got predatory practices, not all bail functions are, but we have predatory loan practices, so people do get out of jail. Right? And so they keep their job and the kids don't go into care, but not releasing people pre-trial has ramifications. People with mental illness are likely to make bail and are less likely to make bail and remain in jail longer before bail. 48 days versus 9 days. A study of the Council of State Government came up with that study. So some strategies that we suggest that we've seen as promising practices are eliminating cash bail for low-level charges, expanding unsecured bond, or use non-financial conditions, sending court dates being via text reminder, and other creative ways in which people who have mental illness and substance use are able to get out of jail without having to languish in jail. So the essential elements of Intercept 2 are prompt releases and detained decisions, meaning like make a decision quickly with this population. Timely first appearance with representation. A lot of times when somebody is mentally ill, maybe the prosecutor will be there, right? But there's no public defender. And how long does it take for the public defender to get assigned to somebody who's in need of public defense?
And even after being assigned, they actually need to get
Prior to, so.
Right.
Can that individual, does that individual have transportation to get?
Yeah, right. So then if they don't have defense at first appearance, they go back to the jail, right? And wait another court date, which has been continued. Screening for primary mental health and disability. We talked about comorbidities and access to health-related treatment. So Intercept 2 is really, really quickly, but it's also very important to have the people in the room, especially for your local jurisdiction to kind of walk through that initial booking process and actually any screenings that are taking place during that initial booking process. And not only the screenings, but the releases of information. Like if I tell you that I'm taking Prozac in the community, right? Then can I take the Prozac that I was arrested with? And if I can't take the Prozac that I was arrested with, then how soon can you give me a medical doctor to evaluate me? Say, yes, I do need Prozac. And I can get it. Right. So the ramifications of people coming off the street on medication and being booked into jail. And if they're not able to keep their personal property, meaning medication, and taking it administered through either a correctional officer or probably an LPN, right? If that doesn't happen, how soon can you get that person? First, they need to be evaluated, right? And then they need to be put back on the medication. But releases of information work very well. And you could have folks sign releases of information to the prescriber in the community to kind of expedite that process. So every county, every jurisdiction is nuanced to be able to do what works for them. Yes.
Are these similar challenges to medical?
Yeah.
Yeah, absolutely.
There,
I'm saying somebody need to have blood pressure medication or chemo medication. Same thing.
MAT is rocky because individuals will get locked up and either they won't disclose because of shame or whatever, or there's a disconnect with the providers, and that's a really, I mean that's a life or death type of thing for that individual when it does, and it also affects their treatment plan with that clinic that they're going to, because they might have to start all over. They could have been getting taken up. There's all types of things that it hurts for.
Something we struggle with is folks that are on long-acting injectables
Okay.
for serious mental illness.
Yeah.
Become incarcerated in the
Right.
jail system, and they won't give them the shot. They transfer them back to pills,
Right.
and it throws them completely out of whack.
Right.
Because they can't get somebody to come give them a shot in jail.
Yeah, because they get the long-acting injectables in the community, right? As part of their continuity of maintenance. Or there's a crisis where you bring somebody who's completely out of it and the facility won't take them. Or you got to transfer them to ER. They give them an injection of Haldol stabilize them for 10 days or 2 days maybe, send them back to the jail, and it's not on the formula. So now I'm stabilized for this medication, but now you don't have the medication to keep me stable. Okay? So it's so very, very important to know who's coming into your jail, and the sequential intercept model mapping workshop digs that deep and gets that granular. Okay? Because these folks who have low-level offenses don't need to be in jail. So, but what is in the community to be able to have them in the community? So law enforcement says divert to what? I know you want me to divert them. I know you want diversion to happen. I know they don't need to be in jail, but where do I take them? And all of those different nuanced programs, yes. And through that intercept mapping workshop, you develop strategic action plans, and maybe it's bringing a co-response to your jurisdiction. Maybe it is, lobbying to get a law enforcement drop-off center, a 24-hour center. Something needs to be done, and rolling out this throughout North Carolina will show you each situation, because not everybody is the same. So intercept 3 has to do with your specialty courts, your jail, and your dispositional courts. When you're talking about your specialty courts, you have to know what the eligibility criteria is, right? Who are the people they're taking, who are the people they're not taking? A lot of times that's not known, and public defenders are not knowing of what the eligibility criteria is. So that's a way to get folks out of jail early into a specialty court. But what boxes need to get checked, right, to be able to be eligible for this treatment court? Once that person is admitted to the treatment court, what does that programming look like? And not only the programming, what does it take to graduate? And if you have a treatment court in your community, what's your graduation rate? If it's DUI, DWI, if it's just SUV, if it's a co-occurring, if there's a mental health, you have to have your specialty courts in your jurisdiction at the table.
Even SUD, it's a big substance.
Right.
Opiates versus.
Yes, breaking it down even that further. Now, with specialty courts, I see it all over the country where they can maintain 80, 90 people and they've only got 10 or 12 people admitted. Why?
They don't know what to do with stimulating.
I think also people don't know what the eligibility criteria is. I think also some sanctions need to be changed, right? You're talking about it's hard to pick drugs, all right? So when you have sanctioned late to the appointment or lost housing and they're out of the special, whatever it may be, there needs to be some type of best practices embedded in your specialty courts that allow for people to have hiccups, right? Which will increase your graduation rate. So when you have treatment courts and the people at the table, ask them, what's your graduation rate? How many people that you're admitting are graduating? And those are dollars too that could be used for, other places. If you're only historically going to be utilizing this 10 to 12% of your budget, maybe we can divert, right, countywide this money to Matt in jail or somewhere else. Folks who aren't admitted to specialty court stay in jail, they get court appearances, there's dispositional courts, and they either max out or there's conditions of probation. So, courts in jail. So diversion and alternative case processing, you all know this, constitutional protections. A lot of times people self-disclose that they have mental health or substance use concerns. And then because once it is documented what has to happen, they have to receive services, constitutional, right? They have to. And competence to stand trial is a big thing. A lot of folks feel sometimes the public defenders will raise competency issues, okay? And so that kind of will slow down the process where I feel that my defendant is not competent. So now what is your process in your community? How do I get a competency evaluation? The judge sees that I might not be competent. He signs an order for an evaluation, right? They go back to jail, receive that evaluation. How long does that take? 10 days, 12 days, 30 days?
Not getting there.
Yes.
I'll throw out, we had a real issue with this last year
Mm-hmm.
at our jurisdiction. Because what we found out was they had created a list at the courthouse of people who had been previously found incompetent to stand trial. And any new charges or anything that were coming in for those folks, they were getting dismissed before they ever hit the first level of the justice system. And a lot of people didn't realize that that competency is not a label that attaches to you and stays forever. Every time you come back in the court system, if there's a competency concern, you're supposed to be reevaluated. So by doing that, they ended up, it was a legal shortcut to not have to deal with cases, to get cases off the docket. But by doing that, they cheated both sides of the system. Because they cheated the law enforcement side where we had some pretty serious offenses that were going on, people who were perfectly in a right state of mind at the time they were doing it, right? And then on the other side, we have people who are not getting reevaluated, whose cases being dismissed, who had they been reevaluated, might have the door open for additional services.
Yes.
So I would say if you just be on the watch out in your jurisdiction. If you notice all these cases get dismissed before they ever make it to level 1,
Yeah, competency is big.
you might be doing.
Competency is big. I know New Orleans, when competency is raised, they keep them in-house. So they send them to the state hospital. And it might take 18 months to get evaluated and restored. But by the time they come back to New Orleans prison, parish, they're waiting for the court date. And because there's such a backlog and people get lost, now I need what? To be restored to competency again. So now I'm back at the state hospital, and you could be in the system 3 to 5 years. So knowing your competency evaluation in your jurisdiction is paramount for this specific population, especially for law enforcement, because they are on the street, right? They're arresting these folks and they're realizing that sometimes things get slipped through the cracks. So timely processing of court, whether it's dispositional or competency to stand trial, is very, very important. Yes.
Just to add one piece from within the jail side, working in the jail setting, the competency of having a guardian as an adult ends up being a pattern word. You might be trying to get services and find out they're not a legal guardian. The second you start to try to figure out how they're doing legal guardian, you've got, medical staff, law enforcement staff all basically trying to shut you up because, okay, that could affect what's going on now. And so it gets even complicated when you're in the system trying to serve individuals, just trying to find out, am I supposed to be talking to them because they're not even their own current legal guardian, separate from what is going on for that complication. You are trying to work with somebody who's trying to get released on bail. That is
within the jails too, it says individuals that are incarcerated in jail.
With each other.
Yes, and sometimes there's gaps between pieces of this too. So like you have people who commit misdemeanors frequently who have chronic mental illness, but the charges that they have do not meet the criteria to qualify them for a wellness court or mental health court. So now you've got VAs sometimes that are dismissing charges because they're like, oh, it's because of mental health. But now they're falling through the cracks and not getting any support, and they're just cycling back through.
Right. And that has to do with the discharge planning. Does your local jail have a discharge coordinator? And not just, but discharge at every avenue. If it's pre-booking diversion, or if it's first appearance, re-entry, or if it's through specialty court, or if it's dispositional court, re-entry happens at so many points on the model that your discharge team or capacity should be able to handle any portion of discharge in the continuum. Yes.
apologize. We talked about this in the beginning. But is this, so we're strictly talking about adults at this point, but is DJJ, can there be a simultaneous around when you're talking about under 18s for this as well? Like, is there a different
competency criteria, and you know what I'm saying?
Yeah, so we had developed juvenile justice in that, we call crisis intervention.
Okay.
But as of last year, we handed over that body of work to NISAP, to Dr. NYSAP. And it's similar, but it's different, because there's two different types of things. There's a system of care, and then there's a juvenile justice. So the system of care is really working with the schools, the community providers, working with the family, working with family services, and everything that happens under the roof of the house. The JJJ sim has to do with just the legal piece of juvenile justice, and if they're going to a regional youth detention center. Yeah, so there is this type of training, but we no longer have that, and I'm happy to get you connected. Adults in the criminal justice system with behavioral health and substance use. Okay.
Past experience trying to come up with these three factors. In a meeting, study 7 or 8. How often do you come to a sort of decision of what to do, or do you end up with 8 people who disagree?
Yeah. You know how consensus happens through summits? Getting everybody in the same room. We hold a lot of statewide summits and bringing specific people from specific agencies who have the positional power that when we walk out with this room is gonna happen. So they're called statewide summits, and you guys can put that on as facilitators as well. But you generally get consensus once people start understanding the severity of the problem and where's the gap in the system. It happens a lot with the evaluation. Judge says, yeah, they need an evaluation. Well, who does the evaluation? Does it mean I need to pay Dr. So-and-so $900 to do this evaluation in 72 hours, and that's what I need to do? Versus waiting for the community health department to pick it up in 60 days. You know, it's about the evaluation. It's about getting that evaluation back to the judge and getting back on the court calendar in a sufficient amount of time, determine, yes, I'm competent, or no, I need restoration. And if I need restoration, am I getting an outpatient or inpatient? There's so many different questions that can be handled by people who have positional power at a statewide summit. And then once you're restored, do my charges go away or not? Right? And then what does restoration look like for the normal person? Right? And then once I am restored and I go back before the judge, what does that look like? So you can map it out, but it's a matter of having the people in the room that can sign off and say, this is what we agree on. All right, so jails coordinate with community-based providers, other jails, prisons. You all know this. It's the timely access to healthcare. Veterans. I didn't hear any veterans here, right? Yes. Oh, here we go. Yes. So identification of veterans is something that we like to and make sure that we promote. The VA should have at every local jail a veteran justice outreach program coordinator. And that person, once they are identified that they are a veteran, doesn't eliminate everything that's going on with them, but now you've got a specific case manager who's hired by the VA to be able to help them navigate through the system. Anybody know their local VJO?
BJO is actually the healthcare system.
Yeah.
So it will be like in the jail, this local jail should know who the BJO is for their region. So each VA healthcare system, they have one or several BJOs covering.
Yeah. So certain jails will have like office space, usually like a closet where they cop in for a day and a half, and then they cover 4 or 5. But every jail should know who that BJO contact is. Yeah, and identification. You know, hopefully there's a screening tool that says, "Are you a veteran?" Right?
We started with that.
Nice. Wonderful. Yeah. Excellent. How did you realize that there was a need? Like,
It's been something, they've been talking about drug court.
yes.
done it, and then with the veterans, the fact that it was mental health and substance abuse.
Okay.
with Veterans, just like you said, right, and, counties, their brothers,
Okay.
trauma, that, you know, you like to do like that. We're, man, the group up here is actually working fire.
Okay.
Right now.
Nice.
With the, still in that.
Excellent.
Nice.
It makes a difference. Mhm.
Because it's that one-on-one mentor.
Yes.
You-
Mm-hmm.
People that don't have any help.
Right.
But we have, you know, the partners in place to help with that.
Yes.
It's also money. This kind of thing is probably about 6 weeks and pay hotel bill.
Oh, wow.
This veteran, and it's 80 for the
Nice.
cover, just from the partner.
Mm-hmm.
So these things.
That's doable. It is doable.
A lot of collaboration.
Yes. Mm-hmm.
One of the, on the slide you had up before, it had squares in the bottom.
Yes.
And this squares in the program where you can look up individual, veteran eligibility. There's a lot of folks that say they're veterans, may or may not be awarded, they don't know what they're eligible for. But that program is available, for law enforcement programs. It's relatively simple to get signed up, and in Mecklenburg County, our dispatch has access to that program, so we can figure out on calling for that information. And then that identification of that veteran can be done right away, giving some right services for the SEO. It's in jail, that information will pass along and connect them with the jail. Earlier, you can identify that, more like talking about.
How did law enforcement get squares? Download on.
So I can say each community has a regional manager of the squares access. For us, it was through our veteran services, our county veteran services. So at the very least, getting in touch with our county veteran services to see if they can issue a test. If they're not the actual manager of that access, then they should go to managers. Ours is great for the department. The squares exclusive to for law enforcement. But frankly, not a lot of that. Not a lot of law enforcement.
So any police chiefs, right, or assistant police chiefs may want to look into, especially if they have a large veteran population in their community, of getting squares onto their devices for officers. Is that free?
Yeah, it's just a VA database. There is like, you have to complete some training to access the VA database. Access points through IDGs, so you have to do a login. Plus, the easiest thing to do, because you have to get in every 30 days, something like that, otherwise your access expires. For us, the easiest thing to do is to put it in dispatch. Every individual officer may not use it that often, but if there's a few people in dispatch who can provide that information, they're actually not worthwhile.
Excellent, thank you. Yeah, see this information, this is what happens at your center, right? All right, so we have pre-plea, post-plea, and probation-based alternative sentencing. These are diversion and interventions that are encouraged through the working with this population. We ask that people have consider the caveats of probation-based alternative sentencing, meaning that most of this population sometimes access entitlement benefits, right? And so now if they have taken a plea, they might not be eligible for certain type of housing, certain type of benefits, food benefits, and for tuition suspension, a variety of different eligibility programs that historically they may have benefited or their families have been. But pre-plea is just that, it's without a conviction, case is dismissed with successful requirement completion. Post-plea, it's deferred or a modified sentence, and probation-based alternative sentence, meaning that there's a condition that needs to be maintained while on probation, which is generally some type of successful completion of treatment. We kind of went through the treatment court, so I'm gonna skip over that. So jails and in-jail services. So when they go back to jail and they're waiting to go back to court, to the dispositional court, we ask what type of services are being provided while they're in jail. Are they getting any type of mental health or substance use or MAT services? is there an evaluation that has taken place that generates an individualized treatment plan? That generates an initial evaluation by a psychiatrist or a psychologist that will then establish contact standards that that person is seen by somebody at least 1 or 2 times a week? What type of services are there? Supportive housing living units in the jail, or is everybody housed together? So when we're looking at someone with mental illness who's a very vulnerable person, or somebody with substance use, are they housed with the general population? Or do you have specific units and pods where we can house these folks in? And access to medications, just, we can't beat that to the ground, right? If they're on medication in the community, somebody's prescribing it, right? And so how soon do you do the release of information to get that information from the prescribing physician? Or if they're able to keep, they came in with the medication and they're able to keep their medication, that's the win-win for everybody. But if not, how soon does that person get evaluated either by the facility doctor or a psychiatrist, because only a psychiatrist or a PRN can prescribe psychotropic medication for a medical physician. So how soon does it take to get that person in front of someone and MAT services, SU services? And communication with community-based providers. If that person is receiving services in the community, you should have communication. And shouldn't that all be cut off? We talked about working with families. And I've seen the reverse side of that as well. You know, they've gotten in jail and what do I do? And help me move along. When you have families involved and they're very supportive, they know who those people are that they're receiving services from. But then we've got guardianships and that problem over there that we talked about, that how far can I go? I've also seen the other side where I have a mentally ill kid and I know he's safe in jail. All socioeconomic levels. Okay. So specialty treatment courts, drug and DUI courts, mental health courts. We talked about these: veterans court, domestic violence, tribal wellness, and reentry courts. All right. So how many know your jail health provider at your local jail? What is it? Medical. Throw me out some more names. WellPath. Does WellPath work in North Carolina? Vital Corps. Okay. Horizon. Any universities provide services? No. What is the local university here? One of the big universities that might have a medical college. Wake Forest. Okay. How about your community health departments? Are they providing, anyone know of them providing services? Medical, mental health, or substance use services?
Yes, Harvard County is using community health workers to help link to different services outside of county.
Which county?
Catawba County.
Catawba County, okay. So we've seen districts and states use local universities, like New Orleans uses Tulane University. Atlanta uses Emory University. And what they do is they use their interns with psychiatrists and psychologists. So now they have an immediate access to a psychiatrist. Does it cost? Yes, it does cost. But you have always got a constant flow of that upper level provider, right? Having access to the people who need them. So Tulane has had a, WellPath is in the jail. Tulane has a subcontract through WellPath. And then they will come in and make those initial psychiatric evaluations and write the scripts and do the medication management that's necessary when somebody's on psychotropic medication. Because you know you got blood draws and you have to do a whole bunch of checking the boxes, right? So, but they had a constant flow of staff. And a lot of communities can partner with medical colleges. They're getting, the medical college is getting internships and field placements that they normally wouldn't be able to have experienced. I come from the era where, who's from, anybody from New York? Pilgrim State Psychiatric Hospital, remember that? Kings Park. I come from that era where you had these institutional, right, buildings that you could see everything in the DSM-5, everything. Okay, yeah, that's what that is. All right, that's what the type of experience these universities get when they utilize prisons and jails, because it's so different than textbook. Okay, so we encourage folks that if you have people on the boards to see whether, and especially if you're having a hard time filling those positions, start some talks, have some talks. All right, so, but there's providers who are out there that have accreditation through NCCHC, National Correction Healthcare, vendors, jail contracts. It's very expensive. Or local county health department and or jail provides jail healthcare. Very few counties I know don't provide any type of services, whether they're bringing people in on a per diem basis. All right, Intercept 4. Any questions? A lot of lively discussion. That's a good thing. All right, so reentry. You have two types of reentry: prison reentry and probation reentry. Jail reentry, which is probation. When you're doing sequential intercept model, working mapping workshops, the people who are responsible for reentry, we make sure that it's prison reentry, because again, when people from the prison are reentering back, they're reentering back to the local community, right? And sometimes things don't go as well as everybody anticipates. And they end up where? The local jail. All right? And jail reentry. And that could be a whole bunch of different avenues, whether it's, again, first appearance or dispositional court, maxing out, or through treatment court. So 30,000 people were released in Washington State Prison. 443 died during the follow-up period. Okay? Reentry is a matter of life and death. So when we talk about reentry being a matter of life and death, having a plan in place so people have their concrete needs met. The majority of the reason folks die is they die by suicide. And they die by suicide. And thirdly, overdose. Post-release opioid-related overdoses is the leading cause of death among people released from jails and prisons. Does that surprise you? Mm-hmm. Yeah. Do you keep it, who's the coroner? Do you guys all know who your local coroner is, and do they track stats? Opioid-related stats? Also, your facilitators, it might be helpful to have somebody or designee of your coroner at your sim workshop. Kind of talk about those things. So we talk about reentry, we talk about case management, right? Case management is key towards discharge planning. You got to look at food, you got to look at housing, you got to look at childcare for those who have children, employment services, clothing, medication. There's just so much going on for someone who's already a vulnerable person, right? It's difficult dealing with all these systems, me and you, right? So think about someone who's suffering with mental illness and or substance use, all right? Case management is critical. So income supports, childcare needs, health. How does your local community or jail handle discharge? How does it handle reentry? Is there a specific dedicated case manager that helps with discharge planning? And if not, what happens? All right, you're released, what happens? See you later, bro. All right. And what time do you release them? It's just amazing.
30, 11 o'clock at night.
Where there's nothing else but to get in trouble.
With no shoes on and no coat on. It's 22 degrees.
Yeah.
No.
Nobody's open. Yeah. So sometimes when you have specific people in the room during a sequential intercept mapping workshop, and you have the sergeant who's over discharge and releasing folks, because I've heard one guy say, and it made perfect sense. He says, by the time I get the signed order from the judge, it's 4:30, 5 o'clock, shifts are changing, I'm trying to hand out meds, I'm trying to make sure everybody's locked down, and that's the only quiet time where I can send somebody back in the room to get all their personal effects and send them out right away at 11 p.m. But when he heard the whole story from Intercept 0 to this, he said, okay, I understand now. I understand that I need to get this person released at least between 9 to 5. So if they need help, they can get on the phone and get some type of, okay? So that type of collaboration and information is just critical. And then again, the multiple systems that a person has to encounter. Facility to community transition, SAMHSA, and these links are in the Hoover app, but SAMHSA has wonderful pamphlets that talk about the reentry framework and using the utilization of validated risk needs screening tools and integrating in reach for providers. Facilities that allow, so I know I'm getting discharged February 28th, right? I know I'm going to ABC Community Behavioral Health Provider. The local sheriff has said, okay, ABC, you can come in 10 days before I'm discharged, do my intake, right? Find out what my needs are and make that a warm, smooth handoff. A lot of sheriffs don't want to do that, but having in reach before that person gets discharged, to the extent that you can, saves you from seeing them again in 2 days. Focusing on addressing stability needs in the first 24 hours, 1 week, 3 months, and 9 months. All right. So there's wonderful best practice manuals that are out there in the event that you feel that your community is somewhere that you want to try to at least start the conversations about what does serious discharge planning look like. All right, we won't get into Medicaid 1115 waivers. Because you're not a state that has Medicaid waivers, but in December, you are? Oh, when? Oh, okay. I think it's fine. Tell me about it. When?
So CMS just.
Infancy.
Phase, but that.
So why don't you tell folks how many people know what 1115 waiver is?
So I just actually did this recently for a class at ACT. So Center for Medicaid Services, Medicaid is services billed for and due under Medicaid. And they have what they're called waivers that waive some of those to allow you to do different things. And then North Carolina applied last year, we have 5-year waivers applied last year. And received the approval to move forward with the 1115 reentry waiver, which is going to allow people who are incarcerated, jails and prisons, to have Medicaid started within up to 90 days of release and has certain services that are listed in it that they can potentially get mat in the jail, all kinds of mat, not just one mat or the other. 30-day prescriptions when they come out. Tracy New York speaks something more to too, which comes in. 30-day prescriptions when they come out, case management, access to programs while they're incarcerated, DME, those kind of things. I know the state is still in there. They have 128 since 1115. So I don't know where we are with that because I work for one of the managed care organizations, but it's part of my role in my organization monitoring and seeing. So that was just mid-December.
Oh, wow. Okay, yeah. That's great. So how is it a game changer, Tracy?
How is it a game changer? Well, hopefully it's going to that people can get some care coordination for them. So I'm hoping that it's program
who have felony charges, violent charges, and a diagnosis of and the care coordinators from the FPOs go in, they can start that planning. So hopefully when they get out, there's things in place for them to plan. So we're excited about that. It's going to be here, and it's going to be care coordination, not only for the individual, but as a mind, it's also how you do it. I'm really excited about a lot of work that's got going.
Nice. I have to update the slide. Yes.
Current reentries that being started like literally before reentering, or is it starting like as you know the day or two that they're in there? Because reentry should start, in my opinion, right off the bat.
Yeah, I think yes, but the 1115 is 90 days. Yeah.
Is there,
Do they have to be incarcerated for a certain period of time before this kicks in?
I think it just, they have to be up to between 90 and 100.
And, you know, in the West Coast, you see it. It's not that prevalent over here. 11, 15 waivers, but it's game changers.
They can say, oh, this person. No. There's a lot of what with the reform capacity thing that has been trying to go against. Presents help and control access to. What is it, 90 days?
Yeah, that's just the
The
waiver.
the waiver was, you go deeper, into the waiver is come out of the court, say back to 2018,
Yeah.
where it was around the opioid crisis. And they were part of that act, probably.
Because historically, Medicaid would not pick up services in jail. Okay, you get dropped. So now this not only continues people's ability to receive Medicaid, but start the services that they need before they get discharged. Right, so should, in essence, lower recidivism.
Any advocacy going on?
And kudos to your state legislators, or the governor who signed that. It's the governor who has to sign that.
Is this for pretrials? Like for those that are going in and waiting for their hearing date, and then eventually one day they come to bail and they get out? Will they qualify for this as well? Are we only talking about folks who are serving short-term sentences after conviction?
That's a good question.
I say I've read the waiver, I'm not 100% sure, but I know that the state has.
Well, that's true. I had thought about that. You can't know you're within 90 days of release if you don't have a sentence. Because we have some people sit there 6 to 8 months waiting for trial.
Can you repeat that, sir?
Do you mind repeating?
Sir, can you repeat what you just said?
I just said, give me a 9, say what you just. If somebody's just in pre-trial, they don't know.
Yeah, right, they're gonna go, that was the state law.
No, I mean, that's what they're saying. If they're saying that you qualify for this 90 days to the end of your release, that means they're gonna have to know when you're dead.
Yes, I understand. My question was, what specific law was that?
Oh, hold on, I've already.
Yes, ma'am.
Oh, I, let me find out, let me find
Thank
out.
you.
It's in my Google.
Okay, at the home stretch. So, community corrections, very important to have them at the table. That's just a little funny that one of my colleagues put up there, that you see the probation officer behind there. He says, I'll be supervising you, and he's got all these cases. And we know that, right? That sometimes, you know, like in a state or a county, you've got 50,000 people on the probation. So how does somebody, and you've got, you know, what, 1,000 people who are probation officers, how do you supervise somebody with a 300 caseload? You don't. All right, so as it relates, this is in the United States. Currently, there's 5.5 million people under community supervision. When I talk about community supervision, I'm talking about parole or probation. 55% are from probation. You can only get on probation from what? Local jail. 10% are in jail, 22% are in prison, so, and 15% are on parole. So from community supervision, somebody who's in the charge of the state, where are the most people at? In probation, serving probation.
Which can often lead right back to.
10% of people are not only in jail, there's enough people in jail, 22% in prison, only 15% of people are in parole. Parole is from coming out of state prison.
Probation can include the federal.
Right. Probation, federal, local.
Well, it can be federal also. It can be on federal probation.
Yeah.
That was
Yeah, not that rare, but the majority of them are local.
We won't really get into that too much. My colleagues are fine. They talk about what's the needs. Have you guys identified these folks? Yeah. Yeah, that happens.
Movies or?
Oh, no, this. My colleague did.
I don't know any of these.
All right, so let's talk about a few strategies for success of probation and parolees. Again, wonderful, wonderful resource through the Justice Center, the Council of State Governments. It talks about specialized caseloads. So you have probation officers and parole officers who only have a caseload for people with mental illness and or substance use and or co-occurring and or domestic violence and or tribal. So when you have specialized caseloads, they're only what? Focusing in on that population, which means that they can get their training, they can get their professional development to relate and to work with those specialized caseloads. Reducing the caseloads allows specialty probation officers to develop knowledge about mental health in the community. They're more inclined to advocate for services as opposed to somebody who has 300 random people, right? Now, when we talk about specialized caseloads, it's not for everyone. Again, just like CIT, it's not for everyone. You've got to have someone who has a passion and wants to work with the population. They also recognize multiple roles, even though they have a legal surveillance role, they have a therapeutic problem-solving role. They want to make sure that this person is getting the services that they need. They don't want to have to replicate them. They don't want them to recidivate. They want them to get the treatment and the services and the stable housing that they need. And the quality of the relationship between officer and probationer strongly influences the outcome. So when you have folks who are doing what they want to do, how they want to do it, outcomes. Peers. My colleague Ashley Pryor developed this diagram, and it talks about peer support roles across the sequential intercept model. Remember, we kind of talked a little bit about peers being inside the workshop itself, but there's also places within the system that you can embed peers, right? Sometimes it's controversial, sometimes it's not. It just really depends on the time of day and who's in office. Yes.
I personally believe that peer support would be very well utilized for individuals that are out of pre-trial, they're facing time.
And there are communities that do. They provide peers at pre-trial, they provide peers during the booking process, they provide peers at first appearance, peers in the court, peers that go along with probation and parole, peers that are discharge advocates. The only issue when you're dealing with anything kind of behind the wire, you know, you've got to get the approval of sheriffs, because generally somebody who's a peer is what? You've been arrested before, or you've had a history of drug abuse and or misuse. But these certified forensic peers are individuals who now can identify with someone who you and me can't identify. And they will be able to help them navigate and walk through the system, encouraging and showing the validation and the importance of peers. The jail administrators and sheriffs really can help with ease management of correction officers, believe it or not. But a lot of sheriffs, which is they're right, that they don't want somebody in their jail that might have access to technology and be able to retrieve, right, inmates' information, and they know that they've had an arrest or substance use.
It's important to know how to work with peers because they're sometimes peers fall back into trouble. So like understanding that. Yeah.
Mental Health America is the national organization. Does anyone know of the Mental Health America? So they're the individuals who will help with the peer training and get with, there's a program with forensic peer training, but that's the organization that generally a lot of jurisdictions rely on for their
peer, support and resilience and their pool. Yes.
UMH, yes, we, included a lot of field curriculum for peer certification. And what we do with the program is that we're taking, we are community action agencies. And we're going to turn 5, 35, in those community action agencies will also do it just as involved. And that would help those persons in those programs, more civilians, including, the community action agency job training program, and also connect them to community health services. So we started with 5 in high needs areas, and hope once we get that, to increase that. But that peer support has been a big push by our director Kelly Cross, our state representative.
So the funds are coming from the state.
Yes, specifically state open, for this state open door response grant money, called SOAR. Yes, sir.
Well, they launched about, maybe you won't working on your car, might have over, might improve it, so. We work with them all the time, and I mean, they hug, they share stories, and they mean a lot. And it works out. It works out well. You will never get that access in the door if you have that.
Here, and they work the same time. Right. So we consider housing as being stable treatment. You hear about treatment, you think about cognitive behavioral treatment or therapy and different modalities of non-medication treatment or medically medical treatment. Stable housing is treatment, bringing a strong chain of housing resources. And what does that mean? Not just having your emergency shelters that are available, but transitional, permanent supportive housing and rapid rehousing, and then permanent housing, which might incline to affordable rental housing. So it's very, very important for people to remain stable if they don't have housing. If they don't have housing. And a lot of communities are getting very, very creative with housing, whether it's in tiny houses or renovating discontinued 18-wheeler trucks. They're becoming very, very creative. Abandoned hotels, taking property away from people who have let their property or large buildings be absconded through owning thousands of dollars property taxes. But stable housing is treatment. People need to know where to lay down. Not everybody. It's hard. It's hard. And now you've got not necessarily people who have mental illness, the substance use, but you have working families historically. Have been able to afford, right? A 2-bedroom, 1-bedroom. They're sleeping in the cars with their kids. So it's not just somebody who's strung out with drugs or mental illness. Housing is stable treatment. Okay, got working families who are pulling in $60,000-$70,000 living in
Unstable housing can lead to,
and it can lead to domestic violence. It leads to foster care, and it leads to substance use and or mental illness or criminal.
It's identified as a basic need.
But not everybody has it, right?
Hierarchy of laws needs.
But not everybody has it, right?
there's No, I know that the percentage is basically the amount of empty houses in communities combined Charlotte and 12%.
Okay, so we talked a little bit about medication assisted treatment, Matt. Some jails offer that, some do not. But there's medication for alcohol dependence, opioid dependence, smoking cessation. And these are the specific prescribed FDA approved drugs for those dependencies.
That's truly illegal.
Yeah, the ADA, but Yeah.
Yeah.
Convincing, yeah, that's very philosophical, right? So identify, coordinate, treat, support, and release. And I won't really get into this, but some jails, it's either if you're in the community and you're receiving it, they continue the services when you get incarcerated, or they induce the treatment while you are incarcerated, meaning that they start that, they make sure that when you re-enter and come back in, that you're hooked up to a community provider who will provide those services.
There's the Vivitrol that is very expensive, it's like $10,000.
Yes, formularies are definitely something we want. So, all right, so cross-cutting strategies preventing opioid overdoses. These are 5 strategies that we share with communities. And there's an overdose prevention toolkit that SAMHSA has put out, encouraging providers to identify and know the people who are high risk, family members. We all know this, right? Ensure access to treatment for individuals who are missing opioids, ready access to naloxone and public call to 911. Do you guys carry Narcan? I guess, yeah. Do you have like places in parks where people can access it with a hammer and a video camera and they get it out?
No, we got it where, our peers will give it out, and the cops will sort it, and they use it on money, that's how we do it, you know.
Okay.
We're trying to do a lead touch for enforcement.
It leaves them behind.
We finally got it in there.
Oh, good. Cool. All right, so here's some of the gaps that kind of always come up when you do a sequential intercept mapping workshop. Lack of formal structure or coordination, meaning like everybody's doing their own thing. Information sharing and data integration, like your most visible persons that are in your emergency room, how much of that information is known to your jail health providers or the law enforcement cross training. And you'll see some cross training that happens inside the workshop itself. Evidence-based practices, trauma-informed approaches, and trauma-specific treatment, cross-system screening for military service, integrated health services and healthcare reform, integration of peer services, housing, transportation, employment, data. So when you get to your intercept mapping workshop and you start talking about what some of your priorities are, you'll see a good deal of these come out from the group. So in summary, using the SIM model to leverage the diverse community brain trust, meaning like everybody has identified what intercept that they are in. Sometimes when we invite elected officials and council members and they come, they're not a part of the system, but they hear, right? And it's really, really helpful to have them here when you do it. And then you guys are considered the brain trust. So SIM is as successful as the people who attend, because they're providing, just like you provided all this information and you guys learned so much, and we all learn from each other, right? That's what happens in the SIM within your local community. You might know that they exist, but until you hear the service provision, right? And some of their impasses that they have to effectually deliver that service, you won't have that except in an in-person meeting. People with behavioral health orders, sorts in criminal justice system, they're what? We all know it. They're heavy healthcare utilizers. They're at risk of early illness and or death, and at risk of deepening exposure into the criminal system, meaning staying in jail until they die or going on to state prison. So one of the goals of the SIM is a seamless transition across the system. Like you see how a person progresses through the criminal justice system from intercept 0 to intercept 5. We want to make that seamless and to develop a strategic approach to not only protect public safety, but improve public. So I thank you very much. I'll take any questions if you have. I know, Tracy, you want to finalize with a few things about implementation, but any last minute questions? Been all great. This is a fun thing. I'll be here for a few minutes to answer any questions, but Tracy, I'll hand it over to you.
If everybody said.
On our integrated family services table, those were actually prizes for a raffle that we were doing.